Hi, my name is Dr. Erika Rosenzweig, and I am the physician-in-chief of the Maria Fareri Children's Hospital of Westchester Medical Center Network and department chair of pediatrics at New York Medical College in Valhalla, New York. And I'm so delighted to be here today to give an update on the World Symposium on Pulmonary Hypertension, which occurred in 2024, this past summer, where experts from around the world met and discussed the latest on pulmonary hypertension, the latest advances. And I was so fortunate to be a part of the pediatric task force. It was only the third time since the meeting's inception that this task force convened and met to discuss specifically advances in pediatric pulmonary hypertension. And so I was joined by colleagues from around the world, and we met for many months prior to the meeting and during the meeting to really advance what we know and put forth a document about some of the highlights on the latest advances in pediatric pulmonary hypertension. And I would say broadly, if I were to characterize the document, which was subsequently published in the European Respiratory Journal, I would say that we focused on looking at the definition of pulmonary hypertension and the classification as it currently stands, looking at risk stratification for children and how that might differ from what is currently available and utilized quite frequently for adults. We looked at the treatment algorithm. Again, a treatment algorithm is readily available for adults, but what we know in children is often based on adaptation from adults and expert consensus. And so we took a look at that. We also looked at some novel approaches to the management of pulmonary hypertension associated with congenital heart disease and some of the real challenges that we face in terms of randomized controlled trials in children. And then for the very first time, we had a section specifically devoted to neonatal pulmonary hypertension that affects our most vulnerable infants, those that are born prematurely, often with developmental lung diseases. And so there's a whole section that was devoted to neonates and pulmonary hypertension. So with that, I'm going to take a deep dive into these areas, really so that I can highlight for folks the important points or bullet points that I hope you will take home from the document and that we try to highlight from the meeting. First, when thinking about the definition of pulmonary hypertension, and I will reference you to this manuscript, again, from the European Respiratory Journal in 2024 with the lead author, Dunbar Ivy. When we think about the definition of pulmonary hypertension, we acknowledge that children, again, they're not just small adults. Often what's abnormal in a child may be in the normal range or low, slightly elevated range for adults. But we kept with the same definition, and we did this at the last meeting as well, even though there were slight modifications to the definition on the adult side, bringing down the mean PA pressure being abnormal to greater than 20 instead of previously 25. We wanted to keep with the same definition so that as these children age into the adult practices, we're speaking one language. We're talking about the same definition. There are nuances, though. For little babies, we often use indexed pulmonary vascular resistance. So pulmonary arterial hypertension definition, PA pressure mean greater than 20, pulmonary capillary wedge pressure or pulmonary arterial wedge pressure less than or equal to 15, and a pulmonary vascular resistance indexed of greater than 3 Woods units per meter square for children. Again, one of the questions that we tried to tackle was asked often by pediatricians: when do you stop indexing or correcting for body surface area for a child? And we came together and decided, or came to a group consensus, that it's realistic to think or to practice that once a child is adult sized or their body surface area is greater than or equal to 1.5, that you can start to sort of lose the indexed calculation or report both the indexed and the non-indexed pulmonary vascular resistance. So that was one take-home point. Again, a common question that we get. If you look in the document, you'll otherwise see a definition in Table 1 that is very similar to the adult definition. Again, lowering the threshold by which we consider a patient to have pulmonary hypertension than what had been previously done. Another important take-home message from this meeting was that while we say the gold standard for diagnostics and confirming the diagnosis of cardiac catheterization, realistically, we found that for very young infants, particularly those who were premature or had developmental lung disorders, they're often too sick to safely undergo cardiac catheterization. If it's done, it should be done in an expert center. We all agreed that is adept and accustomed to taking care of young infants with pulmonary hypertension. But on occasion, one might have to rely on non-invasive estimates of PA pressure. And so in that diagnostic workup, we discussed some of the risk factors that might pose increased risk for a cardiac catheterization. We know that for infants less than a year of age and for infants who are premature, for those on respiratory support, that a cardiac catheterization might have increased risk of complications at the time of catheterization. And it's for those infants that one might consider using non-invasive modalities such as echocardiography. The task force also wanted to reinforce that if one is looking at an echocardiogram for the information about suggestive pulmonary hypertension, you also want to make sure that there are no overt signs of left-sided structural heart disease, such as pulmonary vein stenosis, left ventricular diastolic dysfunction, and other related problems that would lead to post-capillary pulmonary hypertension before implementing treatment. And so again, if one is to defer on having a cardiac catheterization, you want to be sure that you're relying on multi-modality non-invasive testing, not just looking at the estimated PA pressure, but looking at all other signs of for pulmonary hypertension and right heart failure, and doing serial assessments, not just relying on one assessment. In Table 2 of the document that was published, we have a classification for patients with pulmonary hypertension and congenital heart disease that had been previously published. We focused on looking at this and updated it slightly, and you can reference it again. Previous reports have shown that there are various forms of pulmonary hypertension associated congenital heart disease. We know there's the classic Eisenmenger syndrome, or Group A. There are those who have correctable lesions, Group B, and those who may have a small coincidental lesion, Group C. Those patients often behave more similarly to a patient with idiopathic disease, that someone who has no pop-off of the right-sided circulation. And then a Group D, if they're corrected, similar to those with coincidental defects. They often behave like IPAH patients. Well, this group felt it was important also to recognize there's a group of patients, although rare, that may have had a large shunt at birth, but it wasn't in place long enough to lead to classic Eisenmenger syndrome. And so the group added a Group E to this classification as those with congenital heart disease without prolonged initial shunt. And I'll give one example of transposition of the great arteries with an early switch operation. Those kids can go on to have pulmonary hypertension, and they behave again similarly to Group 1 PAH patients. There was also another group of patients that there's been a lot of attention to in recent past, and I won't go into too much detail, except to say that those with single ventricle or complex forms of congenital heart disease often don't fit neatly into any of these buckets. In fact, a patient with single ventricle physiology might not have a very high pulmonary pressure, but they may have slightly elevated pulmonary vascular resistance, and that can lead to worsening right heart strain and all sorts of difficulties. These patients still remain in the main classification as Group 5 patients. I want to talk then on the next topic that we spent a lot of time discussing, and that is risk stratification. This is a big focus of the World Symposium for adult patients, looking at the best models of risk stratification at baseline and at follow-up. Well, for children, once again, this is slightly different. We don't often have all of the metrics that one has for a simple risk score calculation in adult patients with pulmonary hypertension. I'll give you one example of a small toddler who's not able to do a 6-minute walk test. So the risk scoring may not work. Again, children aren't necessarily just small adults, but they have certain aspects of their care that need to be tapered or tailored to children specifically. And so in this document, you'll find a very rigorous analysis of existing data looking at risk factors for poor outcomes for children with pulmonary hypertension. In fact, the team went through an exhaustive process of a literature search and ultimately came up with a table, as you can see, of multiple metrics that rose to having a high-risk impact on outcomes in at least 3 studies. In addition, there were a couple of others that maybe didn't rise to having 3 studies that were supportive, but that the team felt were very important in risk stratifying. And what we did was we just had basically categorized into high-risk features and lower risk features. Remember, with children, there's very few things that are low risk metrics. It's really that if they don't have a high risk feature, they're in a lower risk category. And some of the parameters included the age, with younger children being at higher risk, clinical evidence of right heart failure, again, advanced right heart failure, putting you at higher risk, but something specific to children, growth failure, failure to thrive, specifically a poor prognostic indicator for children, advanced functional class, low 6-minute walk test distance, and high BNP follow suit with the adult guidelines. But then we put in some measures that were readily available on echocardiography, hemodynamics, should the patients have a heart catheterization, and included for the first time some MRI metrics as well. And again, this gives the clinician some tools to start to risk stratify when they meet a patient. How high, what is the need for escalation of therapy? What is the need for advanced therapy in a child who has high risk features? This is really, again, in the work. We hope eventually to have a risk score calculator currently being validated, but we hope to have one similar to the adult patients. But I think this really provides the community with very important metrics that they can follow when they're looking at a newly diagnosed or previously diagnosed child. One other feature in the classification system that we focused on was the genetic burden or the genetic classification of pulmonary hypertension in children. We know that this affects children. There's a genetic imprint in close to 42% of children with PAH versus adults, in which we may only have 12.5% in that range of a known genetic mutation associated with pulmonary hypertension. So this has become increasingly important in including in the workup, including genetic counseling when appropriate, and making sure that one isn't missing an associated diagnosis. And so we are, as a group, we suggest genetic testing for all patients, all children with group 1 disease, and many with developmental lung diseases. I mentioned that at the beginning that we have had challenges in randomized controlled trials, and that is why when we think about treatment, which we're going to go into next, it's so challenging. In children, randomized clinical trials are few and far between. They've been wrought with difficulties in enrolling across the world and in difficulties really successfully completing randomized clinical trials, which means that we're often adapting what we know in adults for children. And so much of what you'll see in the algorithm that was put forth in this guidance or proceedings was based upon real world experience of experts, expert experience, real world data, and also extrapolation from adults. And so in this proceedings, we even have a table number 5, that shows you the difference even between the European agency, EMA, and the FDA. In the United States, there are only 2 currently FDA-approved medications for pulmonary hypertension in certain children of certain ages, whereas in Europe, there's approval for 5 agents. And you can look at that table for specifics, but suffice it to say, we don't have a standardized approach, and much more work needs to be done, and much more support, frankly, for clinical trials in children. I also want to mention that if you look at this treatment algorithm, which is, I'm going to summarize for you if you don't have it in front of you, this was a real focus of this task force. We wanted to come up with an algorithm, again, based on those principles of data where it was available, expert consensus, and adapting from the adult algorithms, but really including some entities that are specific for children. And so the treatment algorithm looks the same. We put a lot of stake in vasoreactivity testing. We never want to miss a child who's robustly responsive to calcium channel blockers. For the first time in this treatment algorithm, we have a pathway for calcium channel blocker use, but we also have another box to remind folks that if for some reason you have a robust responder to calcium channel blockers and they lose their response, they're no longer robustly responsive, then it might require an adjustment of that treatment or to add another non-CCB agent. If you work your way down the treatment algorithm, essentially it's then divided into those who have cardiopulmonary conditions or respiratory conditions and those without. For those without, it kind of goes along the classic treatment algorithm. Again, negative, high and low risk in terms of whether to start upfront monotherapy, dual therapy, or even triple therapy. On the other side of the algorithm, we looked specifically at those with associated congenital heart disease, trying to classify them into, again, A, B, C, D, or E, to determine whether they would benefit from treatment with a targeted pulmonary hypertension therapy. And then finally, another category of developmental lung disorders, which we all agreed could be initially started on monotherapy for PAH, and subsequently, if there was a lack of response or deterioration, escalated to dual therapy. But if we go back to the treatment arm for group 1 PAH, where we're serially monitoring and we're using 1 or 2 or even triple combination therapy, escalating to IV or parenteral therapies, prostanoids, when the disease is advanced. There's also another portion of the algorithm that's relatively specific for children, and that is when medical therapies fail. When they're failing to provide adequate response, we have incorporated atrial septostomy, a pot shunt, and lung transplantation into that part of the algorithm. And they may be used in combination or separately as a palliative bridge, for example, for atrial septostomy and pot shunt to lung transplantation. Sometimes they're destination therapy and sometimes they're palliative, but at this stage, we have incorporated pot shunt, which has become a very valuable tool into our toolbox and treatment algorithm. I want to also mention that there has been recent discussions about the use of sotatercept. Obviously, this was approved last spring, just before our meeting for adults with pulmonary hypertension, but there is ongoing research to determine its potential safety, utilization, and efficacy in children. But at the time of this meeting, there was certainly not enough data to make any types of recommendations with regard to sotatercept in that current treatment algorithm. So again, a reminder, our treatments are based on real-world experience, expert consensus, and off-label use, and that is why it is so important that a pediatric patient with pulmonary hypertension is seen by an expert, someone who has a lot of experience dealing with pulmonary hypertension. I also want to touch on a topic that we spent a lot of time discussing. I would say it's maybe one of the more controversial topics that we discussed, and that's a quote unquote treat and repair strategy. This term has been thrown around for the last several years, now that we have medical agents for patients with congenital heart disease and pulmonary hypertension. I think we can all agree when there's a pulmonary vascular resistance above roughly 8, patient is typically non-operable, so you don't go in and close the defect. If a patient has a low resistance, let's say less than 4, that patient, if they have a large shunt, potentially is typically operable. But that gray zone in between, where the pulmonary vascular resistance is between 4 and 8, can be a real challenge for practitioners. And we're often asked what to do if they're medically treating a patient and the resistance comes down into a more favorable range. Well, the term treat and repair, this panel agreed, sounded too definitive in terms of creating a notion that you would treat a patient with pulmonary hypertension and congenital heart disease and a shunt with a pulmonary vasodilator. The resistance would get into that gray zone and you just close the defect. There's been no data that that is going to be successful. There's not a lot of long-term data. And in fact, a patient could be worse if you've now eliminated the pop-off for the right-sided circulation. However, this group agreed that it's a bit more nuanced, so that if there is a patient with a congenital heart defect that is sizable, the resistance is elevated, and you've successfully treated them with pulmonary vasodilators, and now your pulmonary vascular resistance drops, let's say, into the 5 or 6 Woods units range, your QPQS ratio is greater than 1.5 to 1, and the saturations are normal, that patient might be a candidate for an intervention. And so there are 2 tables in the document, the proceedings, Table 7 and Table 8. One gives some guidance as to who might be a good candidate for surgery, and then who might fall into this borderline pulmonary vascular disease with congenital heart disease group. And then the second table, Table 8, gives the features, clinical, anatomical, echocardiographic, and other clinical features that might be favorable signs that one could potentially partially close a defect, potentially percutaneous with a percutaneous device, or with surgery and a fenestrated closure. For the example, let's say there's a large atrial septal defect and the right heart is volume overloaded, but the resistance was elevated and now comes down into a more suitable range. One could potentially have a fenestrated closure of that device. The important thing is that we have a lot more tools in the toolbox with the combination of medical, interventional, and surgical treatments for patients with what we're now calling pulmonary hypertension, or with borderline PVR and CHD, and trying to abandon the notion of treat and repair as a sort of a complete repair, as opposed to a partial repair. So again, to be clear, trying to realize that this is a more nuanced approach to these patients with elevated resistance. I mentioned that for the very first time, we had a section on neonatal pulmonary hypertension. And I think this is a huge addition to this group. And I want to just highlight the fact that we had one working group to cover all of pediatrics. And this topic could have taken on a task force of its own, because it's reared itself as one of the most common forms of pulmonary hypertension in children. Developmental lung disorders, prematurity, persistent pulmonary hypertension of the newborn are conditions that are faced every single day in neonatal units around the world. And there is a really wonderful diagram in this, it's figure number, 2, that highlights the patterns, the physiologic patterns of newborn pulmonary hypertension. And I think it's so important to understand they're not all the same. In fact, developmental lung diseases or those associated with prematurity can get better with time. One of the few types of pulmonary hypertension that could get better with time. And so serial assessment of these patients is so important. And again, I want to highlight that for these patients uniquely, unlike other patients or older children with group 1 PAH, if they're too sick to perform a cardiac catheterization, let's say they're a premature infant in the neonatal ICU, then we can look non-invasively as best we can with echocardiography and other clinical features to try to determine whether they would benefit from a pulmonary hypertension agent. I want to also emphasize that the phenotype can change with time. A patient with developmental lung disease can develop pulmonary vein stenosis and suddenly react adversely to a pulmonary hypertension agent. So again, I want to underscore how important it is to have expert team taking care of these infants and to follow them and their physiology very closely. And again, there's a really lovely figure number 3, that shows that you can shift phenotypes over time. You can have overlapping phenotypes. So you can have PAH and then have pulmonary vein stenosis. And these can all have interplay, and again, can be important physiologically to how you assess these children. And so I want to conclude by saying, I hope this was helpful in terms of a real bird's eye view of what this task force took many months, actually years, to develop for you, really to help focus in on some of the key aspects of pediatric pulmonary hypertension. And hopefully at the next World meeting, we'll have answers to some of the questions that we laid forth. But I hope this helps to clarify some of these really pressing issues for children with pulmonary hypertension. Thank you very much.